Okay, well, I'm going to start with introductions. Most of you guys know who I am. I'm Dr. Brook Niemiec. This is Dr. Alan Skinner, my associate here. We are going to talk this evening all about antibiotic usages and misuse in veterinary dentistry. So I'm just going to kind of start with just some overview as far as when we're talking about what types of bugs you're going to be doing. Talk a little bit about the bacteremias, reasons that we might have used antibiotics in the past, and then Alan's going to talk about all the reasons why you don't really need to use them, and those few instances where you still might. So, all right, Alan, I'm going to talk for just a few minutes, and I'll bring you right back up. So like I said, most of this stuff, most of the things that I learned about was from writing a book, and I tell people all the time, if you want to learn a subject, if you want to learn anything, write a book, give a lecture, because you have to really know it. And Alan's like, yeah, the research I've done for this has been absolutely amazing. So this is what we now know. This is what a fascinating thing that I've learned. We'll talk about this a little bit more. But it's more bacteria. So when you have healthy sites, you have lower numbers of bacteria. And when you have periodontal disease or gingivitis, you have more bacteria. But what really changes and what really causes periodontal disease is not necessarily an increase in the overall numbers, but a shift in the type of bacteria. Okay? So it's really changing from aerobic to anaerobic bacteria. So anaerobic bacteria are the bad guys. Okay? That's what causes it. So when we talk about, the bugs that we were looking at when it came down to periodontal disease, part of the problem that we had is the fact that we were culturing it based on old-fashioned culture techniques. And the issue with these things is that anaerobic bacteria, as you guys know, are really hard to culture because you have to keep them away from air or they die. And so the issue comes down to the standpoint of the fact that a lot of our stuff that we were doing in the 70s and 80s were probably not very accurate with as far as the actual bacteria. And the other thing that we have learned is that the bacterial flora is different on the surface of the tooth and down into the gum. So there have been some studies that have shown that marginal gingivitis is actually somewhat, or marginal bacteria is somewhat reflective of what's coming up from underneath in the bottom of those pockets. But the deeper the pocket, the worse the bacteria are, and the more difficult they become to culture. So we have a really difficult time getting down here to these subgingivals. So, like I said, skip through that. So, while studies of the bacteria are interesting, okay, we want to look at, everyone wants to find a particular bacteria that's causing the disease. The problem is, we probably are not going to find that. Porphyromonas gulae, Porphyromonas gingivalis, Porphyromonas gingivalis, those are things are all that are associated. But what they're finding, this dysbiosis is a new term that I'm seeing crop up in the periodontal literature. Really what it comes down to is the fact that it's not a healthy biome. What's happening is that biome is becoming diseased. And it's a different, it's basically like different players in the field. So what they've now kind of determined, the fancy word nowadays, right now, is a dysbiosis of bacteria. And that's what it means. If you guys are interested in what a dysbiosis is, it's an imbalance of different types of microscopic organisms. If there's too many of some types and not enough of others, they don't work properly and create disease. And that's kind of why one of those things when we use antibiotics and we get GI upset is because we kill the good bacteria within the GI. So now the bad bacteria are allowed to overgrow, and then you start getting into diarrhea and other issues with that. So it's a shift of the type of bacteria, not actually a particular bacteria that's creating this, okay? So a couple really fascinating things, again, if you're a geek like I am, it comes with looking at this stuff, is that one of the studies that I actually did here is we were looking at the strains of bacteria that were in the different phases of gum disease, whether it was gingivitis, whether it was mild periodontitis or severe periodontitis. And what we found in a lot of these cases when we're getting to that severe periodontitis is the fact that so many of the bacteria using culture-based mechanisms for getting the things they were unidentifiable. There's so many bacteria that are in our animal's mouths, and probably our mouths as well, that are causing this periodontal disease that we've never even seen before. So it's kind of hard to do culture and sensitivity when you don't even know what it is. So we have a really long way in determining what the causative bacteria, and honestly, I don't think we're going to actually find a bug that is causing it. I think we're going to find that it's a group of bugs. Other things that are fascinating that we're finding as far as periodontal disease, and again, this is all talking about why you don't need antibiotics, okay? Because it's not only bacteria that are driving this disease. It's not, and not only is it some bacteria that we don't even know what it is, but there's also some other things that are doing that, where you're looking at Entamoeba is causing that, is causing periodontal disease. That's in humans. In humans and animals, Toxoplasma gondii. Anyone knows about toxoplasmosis? Toxoplasma has been found in gingival samples of people with bad periodontal disease, okay? And then finally, we've also started to look at some of the funguses that are also increased in periodontal disease. So all of these, it's not just bacteria that's driving periodontal disease. And the reason that we're finding all this is the DNA-based testing. So if you guys are using old standard techniques for doing cultures, I'd probably recommend a change. There's a company, we tried to get them to sponsor, but they didn't want to. The company that I used with the study that I did was called MyDog, and there's several products that are out there, but it's DNA. So basically the beautiful thing is, number one, you don't have to have living bacteria. It's not like you have to be so careful with your culture specimen taking that you grow that bacteria. What they do, they can grow it on dead bugs. Is all they don't grow, they just look for the DNA. So number one, it can be done on dead bugs, so that's really helpful with your anaerobic specimens because they like to die. Number two, it's going to get the funguses and these other things. But number three, it's really helpful that if you've already got a dog on antibiotics for a reason, that it's still going to, not culture, but it's still going to tell you what other bugs were in there. So one of the reasons that we have all, and I know Alan's going to talk a lot more about this, so I'm just going to introduce this because I'm really into this stuff. What we have found, and again, like I said, I'm writing the second edition of the Perio book, and the number of studies, I think there's thousands, literally, of studies on the human side that look at a link between periodontal disease and systemic effects, okay? And so what happens is when you get this inflamed gingiva, which is what periodontal disease is, you get this inflammation, and that's the body's capillaries becoming leaky to allow the white blood cells and the gamma globulins and stuff into the gingival sulcus to fight off the bacteria. When you get that leaky bacteria, what happens is you allow the bacteria into the bloodstream. And it's not just the bloodstream, it's not just the bacteria getting in there, it's also their inflammatory mediators, the cytokines and all that kind of stuff that's creating lipopolysaccharides, all that stuff that's causing the inflammation. Two really important points. I'm going to talk about one and let Alan talk much more about another, is that everyone thinks about pus mouths causing periodontal disease. And they do, but it's not just the pus mouth. It's also gingivitis. When you see that thin red line of gingivitis, that's enough to start developing the systemic effects. The deeper the pockets, the more the surface area, obviously the more bacteremia they're getting. And there actually is a study that was just published looking at the periodontal surface area of infection. And when you talk about if you think about our animals' mouths, how much more surface area a small breed dog does than we do, you've got a lot more bacteria. I've been talking about this for years. What I'm trying to do, and one of my friends is working on it, is getting a periodontal surface area. So we can look at if a person has bad periodontal disease, he's going to have, this much surface area for this much surface area. A little dog is going to have this much surface area for that much surface area. So there's a lot more. Stay tuned. But bottom line is we're already starting to see that as well. And then the other thing is it doesn't need to be bad. All it is this bacteremia going. So we talked about this really quick. Alan's going to talk about this more. But when we talk about antibiotics and the systemic effects, and we talk about antibiotics and the bacteremias and how scary that is, number one, and Alan's going to talk to you more about this, the bacteremia induced during a cleaning is the same amount that dog did eating dinner. So that dog has been spreading himself with bacteria daily for years. End of story, for months to years. So that animal is infected every single day. When you treat him, you remove all the infection in the mouth. So when that dog leaves, he has no more bacteria in his mouth, or he shouldn't, or pathogenic bacteria. Oh, but what about the bacteremia? Well, on the human side, there's a study that shows that the bacteremia is cleared within 15 minutes of stopping. So there's no bacteremia when that animal person goes home. And in animals, and this was literally just published, I know Alan's going to talk about it more. I reviewed this study. I was really excited to see it. They did a study on 13 dogs. Number one, they did extractions and cleaning, extractions and prophy. Out of those 13 dogs, only 4 developed a bacteremia. All 4 of those 13 dogs, the bacteremia was gone before they went home. So the bacteremia is gone. It's very transient, and it's the same level that we've been getting. That's why we don't use antibiotics anymore. Okay? So another thing, and this isn't really part of the antibiotics lecture, but it's part of this whole thing of why we don't do some of these things. We don't debride granulation tissue. So you know when you have an abscess tooth, or you have that severe periodontal disease and it's all inflamed, right? You take the teeth out. What we were all taught was to remove that granulation tissue, okay? Which is, in my opinion, wrong. Why? Number one, you have to remember that granulation tissue is not infected. It's inflamed. It's pissed off because it's next to a noisy neighbor, the tooth. That tooth is infected. The tooth is the root of all evil. The tooth is what's holding on to that bacteria, protecting that bacteria. I call it a bacterial fortress. And so it's letting out its army men, which are the bacteria, and it's pissing off that gingiva. As soon as that tooth is gone, the blood cells and the gamma globulins can get into the gingiva and get rid of it. As a matter of fact, it's so inflamed, it's got all those aren't the gamma globulins, that white cell, they're all there. I can tell you in a day that infection's gone without antibiotics. Because the reason that it's a problem is the tooth is holding on to the infection. The tooth is the root of all evil. When the tooth is gone or it's cleaned, all that infection goes away. So the main reason that I stopped debriding the granulation tissue was because it made it bleed and harder to close. Okay? But why are real reasons? Number one, what is the first tissue that inhabits any healing site? Granulation tissue. So you have this beautifully inflamed tissue that's ready to heal. It's, man, that sounds like, yeah, put me together, man, I'm going to be healed. And what do? You rip it all away and make the body restart that granulation tissue. Oh, by the way, I hear people like, well, you should trim it back because it's hard to pass, you tear, especially in cats. Take a bigger bite. What do they teach you when you're doing a spay? Big bites of the linea. Take a bite into the buccal mucosa, which is normal. It'll hold together just fine, trust me. Maintaining the granulation bed increases bony regrowth. If you take the granulation bed away, according to studies, you have less bone. And it will delay healing because it gets rid of that pluripotent cells. And then what they have also shown is morbidity from avuloplasty is well known. Pain. It causes more pain, less bone, delayed healing. Don't debride the granulation tissue. If it's really pussy, sure, flush it out with some saline, but there's no reason to debride the granulation tissue. So I already talked about this. Basically, when you're talking about a little dog, they have way more surface area than we do. Give me 5 years or 3 years, hopefully, we'll get that published. Okay? So what do they do? What are the systemic effects that we talk about from gum disease? Well, we all know about valvular endocarditis. We've all heard about that, which is why a lot of us started using antibiotics with dentistry because we were afraid of endocarditis. Honestly, all that's been disproven. All of the studies that show a link between doing a procedure and developing valvular endocarditis has been disproven. What there is a link is not doing a dentistry and developing valvular endocarditis, because dogs with stage 3 periodontal disease have a 6-fold higher risk of valvular endocarditis. In humans, there is a strong correlation between heart misfunction, decreased function, and periodontal disease. The big things in animals, because again, when I was starting to give these lectures, talking about the systemic effects 15 years ago, there weren't any veterinary studies, like none. Okay? Now there's probably 25 to 30. There are dogs and cats. There are studies. The number 1 risk factor for chronic kidney disease in cats is severe dental disease. The number 2 risk factor for chronic kidney disease in cats is moderate dental disease. Then it's age, and then it's diet and vaccination status. okay? So periodontal disease is highly linked to renal disease in dogs, people, and humans, dogs, people, and cats. Hepatic disease, dogs and people, okay? Canine cognitive dysfunction, okay? This was one of my residents, Dr. Dewey, did this study where he showed that dogs with periodontal disease have an increased risk of having canine cognitive dysfunction, age-matched, okay? And then an increase in inflammatory markers. All these things are seen in people, dogs, cats, okay? In humans, you also see arthritis, especially rheumatoid. Diabetes mellitus is a massive one. I mean, I will tell you there's probably 300 to 400 references on periodontal disease and diabetes and their bidirectional relationship where one worsens the other. People with bad periodontal disease die earlier than people in good periodontal health. They do. They absolutely do. It's got a higher risk of early death than smoking. So the only other thing I want to talk to you guys about with this is the fact that when you treat, hey, Lee, can you find Alan for me? When you treat, oh, there it is. When you treat gum disease, that means that bottom line, these things get better. So in that Dewey study, they showed that if you have periodontal disease, you have a higher risk of having canine cognitive dysfunction. If you treat the periodontal disease, your canine cognitive function improves, okay? Same thing with kidneys. Nothing in animals yet, but in people, if you're pre-dialysis or on dialysis and you treat the nasty mouth, that improves. Diabetic control improves. Rheumatoid arthritis improves. Dementia improves. Inflammatory markers improve. All these things improve. So is there yet a cause and effect? No, there isn't, okay? But hopefully over time, we will start developing that cause and effect relationship because we really just don't see it. So for those of you, you guys don't need to do this. For those of you guys that are here, you guys are going to get a paper certificate, okay? For any of you guys that are watching online, right now, while I introduce and bring up Alan here before we go on, this is a QR code if you grab your smartphone, if you're not watching on your smartphone. If you're watching on your smartphone, take a screenshot of it. But this is where you can download your CE certificate. So if you're watching this virtually, if you're somewhere else in the world, this is how you're going to get your CE certificate off of that QR code. If you're here locally with us, you're going to get a paper one before you go.
It's also a bit of mine.
What's that?
I also put it at the end of mine.
Okay, so it'll be, for those of you guys that are watching virtually, you're going to have that opportunity again. So that's my introduction to this. That's why I am so passionate about it. Now I'm going to bring up Alan, and Alan's going to take you through the rest of the evening.
I'm going to show you guys this real quick before, if I can get it to play.
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, of course, thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads, until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And then you see the different mutants repeat this at 100. And after about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
That's it. All right. So I just wanted to show you guys that initial video because I thought it was pretty cool, one. But to just how quickly, I think that was E. coli, can figure out how to get past antibiotics. There's a lot of human research on it, but there's not a whole lot on the veterinary side. Like Dr. Niemiec talked to you guys about earlier, I saw a lecture at the Veterinary Dental Forum that I think the guy was a human periodontal surgeon, but he kind of took all the data out there and made it somewhat interesting. I'm hoping to replicate that more on the veterinary side, but yeah, there's just a lot out there. So some of it's dense, but most of it I tried to make not super dense. So, all right, so bacteria, there's a crap ton of bacteria out there. 5 nonillion. My daughter has a book that goes through all these big numbers, and so that's how big a nonillion is. So lots and lots of bacteria out there in the world. They've been around forever, 4 billion years. Most of them are multiplying roughly every 20 minutes, and then there's almost as many bacteria in your and I's body as there are cells. So think about that. All right, so before antibiotics, everybody died. That's basically the gist of this. Staph, so you could cut yourself shaving and die from a staph infection. If you got sepsis, you died. 90% of the people died. Same thing with TB. So TB, at the bottom there, the treatment of choice was to just rest and seek clean air, which we all know is not going to do anything for that. But then all these things that you and I kind of take for granted, because one, we don't have to worry about them anymore, but simple infections turn into really bad things when you don't have antibiotics. So just to compare that, whenever there wasn't antibiotics, infectious disease was the #1 cause of death. Now, heart disease, stroke, COPD. Down at the bottom, or number 4, is lower respiratory, so pneumonia infections. That's, I'm going to say falsely driven up, but it's supported a lot by third world countries that don't have access to good antibiotics, or only antibiotics that are resistant to the bugs in that area. It also elevates the diarrheal infections too, which are farther down the list. But so penicillin was the first antibiotic discovered in the 20s. It sat around for about 10 to 15 years until World War II came around, and then all of a sudden people wanted it. During World War II, they say it saved millions of lives, which is kind of a vague thing, but there were a lot of people that would have died just from simple wounds that made it. 20 million from the 40s on, but the most recent data I think was from 2019 or 2016 and 2019. So 20 to 30,000 lives in the U.S. alone that antibiotics are saving. The thing that sucks about antibiotics is they're really hard to develop, and there's no money in the end whenever you develop them. All the money is going into cancer research and chronic disease, because cancer, there's no limit on how much people will pay for that treatment. And then chronic disease, obviously chronic disease means you're going to be on the medication forever. So that's where all the money is, because antibiotics, you take one course and you're done, hopefully. And for a company to put all that money into it, into the development, and then have the patent go away in 15, 20 years, it's just not worth it for them. So the last new class of antibiotics, or major class of antibiotics, was in the 80s. So pushing, 40 years since the last new antibiotic class came out. And the last gram-negative bacteria targeting drug was in the 60s. And you'll find that most of the antibiotic-resistant bugs out there are gram-negative, so not good. So here's a picture that I stole from somebody. But it really shows you like all the different antibiotics being developed, and then all of a sudden, there's the last one, and then it goes away. So today there are 31 different classes of antibiotics with 150 total, roughly 150 total antibiotics out there. I'm going to go through mainly just the ones that I feel like we use. And please don't memorize this. This is just little tidbits. There's not going to be a test at the end or anything. This is like, it gave me stress, a lot of stress from vet school and stuff. So most of the time we're using beta-lactams. The big thing here, it inhibits the synthesis of the cell wall. The higher generations are more resistant to the beta-lactamase that causes resistance to these antibiotics. And then you can also add the beta-lactamase inhibitors, like Cloudmox and Augment and things like that, have those potentiators with them. You can get allergic reactions from penicillin, as everybody knows. So penicillins, there's narrow spectrum and extended spectrum. You'll find that I'll use the generations, and if there's not really a good veterinary antibiotic in that generation, it'll just be blank. So you've got the first, second, third, fourth. There's kind of fourth is divided into two, but there's, I can't even say that word, so I'm glad. There's nothing there. But most of the ones are going to be like your Pen G and Pen V in the first gen, which are very sensitive to resistance from the beta-lactamase that they pick up, that the antibiotics, that the bacteria pick up to be resistant. The extended spectrums like amoxicillin and ampicillin are the ones that we probably use more frequently. Cephalosporins, also ones that we use a lot. The one that everybody talks about, but no one really, like, we always talk about why are we using Convenio, which is a third gen cephalosporin as often our first line of defense, because we should be using cephalexin or cefazolin. But then you also, what are you going to do with cats? But you shouldn't be doing that technically. You should start with the first gen and then work your way down, which we'll talk about a little bit later. Imipenem and meropenem, kind of the last line of defense. I've seen them used in specialty hospitals and vet schools and things like that, but most of the time we're not bringing those out, hopefully. All right, this one's just basically metronidazole. The nice thing with metronidazole, it also has a protozoal activity or antiprotozoal activity potentially. And they don't mess with the oral bacteria or the gut bacteria, the aerobic bacteria, so that's why we use them a lot for gut stuff. Also, the interaction with the anticonvulsants, things like that, neurotoxic high dose, not usually a big concern, but if you got the right pet, it can be a concern. Macrolides, so Z-Paks, things like that. The big thing about this is you shouldn't be mixing those with clindamycin, just because they do the same thing and they kind of make each other not work as well. And then lincosamides, if I can say it, So clindamycin's in that one. That's the one that we use a lot in the dental world just because it has good bone penetration. So whenever we are worried about osteomyelitis in the jaw, this is my go-to. That being said, there are some things now to consider that I may not be pulling this one out as much, but I've had good luck with it for the osteomyelitis patients, or the ones that I'm worried that there's potential for there to be bone involvement. This one's a little bit more likely to cause GI gut imbalance or bacterial imbalance, microflora imbalance. And so just be careful with that. But I mean, honestly, I use clindamycin for months on end whenever I have osteomyelitis cases. So, yeah. So fluoroquinolones, so Bacterial, Orbax, things like that. Good penetration into tissue. So if you have a soft tissue infection, these are good. But you do have to watch out for the other side effects, joint, GI, things like that. And then the tetracyclines, so doxycycline. This is another one that we actually had a case today that we were actually talking about adding doxy because we've got this persistent, dead bone, necrotic bone from post-radiation injury that is non-healing wound, and so we're just trying to clean it up, and we've thrown clindamycin at it, and so we're potentially throwing doxy at it just to see if we can figure it out. We'll see. It may just be that it's dead bone from the radiation and we can't really do much with it, but it's worth a try. So, negatives of antibiotic therapy. So we all know about infections, hypersensitivity reaction, GI issues, vomiting, diarrhea, things like that. But the other things you don't always think about are the immune-mediated diseases like immune-mediated hemolytic anemia or thrombocytopenia. Those are things that can be related to antibiotic use. And then you can get C. diff infections. That's one of the ones with clindamycin. And then also resistance, which is what we're going to talk a lot about. So there's so many different numbers here, but this is the most recent data, and then actually some of the older data looks worse than this. They've kind of trimmed some of it back, but over 1 million lives per year directly related to antibiotic resistance infections. And so there's also associated deaths, so people that have concurrent cancer, but then they get an infection which kind of speeds things up, or kidney disease and they get an infection, speeds things up. You can only write one cause of death on a death certificate. So when they went back and looked, a lot of these were sped up because of antimicrobial resistant infections. So AMRs they include like fungals and things like that. So it's not just bacteria, but majority of them are going to be bacterial. They are predicting 2 million deaths per year by 2050. I think the original one was something like 8 or 10 million deaths per year, so it's been trimmed back. There's some encouraging data, some not so encouraging data. So the deaths for under 5-year-olds have come down, but the deaths for 70 and older have more than made up for the 5 and under year old deaths. Of course, there was a decrease in all of this during COVID because no one went outside and no one got bacterial infections, which was good. It actually kind of gave us a little bit of breathing room. But of course, that's kind of rebounded now. So economically, though, it's nowhere near 100 trillion now, but it's in the trillions. And by 2050, they're saying 100 trillion worldwide, just because of the economic input that's needed to keep up with these. So this guy, Alex here, he invented penicillin, or discovered penicillin. And in 1945, which was roughly a few years after penicillin finally made it to market, I think this might have been whenever he was getting right around the time he got his Nobel Prize for this. Yeah, the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin-resistant organism. I hope this evil can be averted. And he did this, basically before, he knew this from the beginning. So he was actually somewhat resistant to making it commercially available. So yeah, penicillin had only been widely used for a little over a year because I think in 43, the end of 43, the war, there was a war council or a war group that pushed to get penicillin built or produced in enough of a supply to support the troops, and that's kind of when it kind of got built up, was in the late 1943. So penicillin in the 50s versus penicillin now. Yeah, I love memes. So I don't have any cool places that I go like Brook does because I have 2 kids, a mortgage, and a car payment. So I make memes. I don't make memes. I steal memes from other people and put them on here instead of pictures of cool places. So you'll see a couple as we go. All right, so casual antibiotic resistance is actually more important than kind of direct antibiotic resistance. So, and this is one that I had to, I don't want to say think about, but kind of blew my mind when I was reading about it, because I always thought that I was, I'm treating the bacterial infection on this dog's leg. That's the bacterial infection that's going to get resistant to my my antibiotic. But it's actually all the other bacteria in the body that just secondarily, picks up resistant genes because they're exposed to it, but they're on the body and they're supposed to be there, so they don't actually go away. They just kind of are there, and they pick up the changes that are needed to be resistant to that antibiotic. So these guys from Harvard looked at almost 100 million outpatient pharmacy prescriptions with 72 different combinations of bug and drug combinations, and then they want to know how much does each prescription affect the antibiotic resistance for the whole population on the population level. And what they basically, the conclusion of this was that one-time use of antibiotics correlated better with population level resistance than the intense repeated use. So the cases that you give antibiotics for months on end, like the osteomyelitis cases, are actually not as big of a deal as the ones that you give for a cold when you shouldn't be taking antibiotics for a cold. So we should focus on these low intensity uses more than the high intensity uses. So that's us. We do antibiotics usually in short courses, so 7 days, 2 weeks. So So bystander effect. So this kind of goes with that, what I was talking about earlier, where it's the organisms that are not being targeted really by the antibiotic or not your intended target. So the normal flora elsewhere becomes resistant. So bystander effect. This is the extent of my PowerPoint knowledge. So treat UTI that has bacteria A in it with antibiotic X, one arrow. Cure bacteria A. That's the goal. That's why it's blue. It's happy. You notice there's still a lot of room on this slide, so there's still going to be some more stuff going on. Or, another arrow, you create resistance of the bacteria A to an antibiotic X. So that's kind of what I traditionally thought happened with most resistance. But you can have resistance to antibiotic X in arrow, strep that's found in the nose, E. coli in the gut, Haemophilus in the respiratory tract, Klebsiella in the gut, Klebsiella, sorry, and et cetera, et cetera, et cetera. So that's where we get the resistant bugs, not so much the stuff we're actually treating. So this is kind of proving that. Yeah. So hospital kitchens is where you get your resistant genes. Yeah. So it doesn't. It's definitely something that's sneaky that you don't think about all the other things that are being attacked. So the good thing is that there is a fitness cost to carrying that resistance around. The drug-resistant bacteria are actually less likely to survive when put in competition with normal bacteria. So if we leave things alone for a while, it'll kind of self-correct. It's just that we don't do that. And so that's where, like I said, whenever we were in COVID land and everybody was staying home, we actually gained a little ground. So there's hope. So what can we do? Know what we're treating, treat only if needed, and treat in an appropriate course. So Brook probably talked about a lot of this stuff, so I'm going to not spend a whole lot of time on it. That's why it's just a list. But you can have all these things, a bunch more things, secondary to dental infections. But most of the time, the mouth keeps things to itself. Whenever I talk to owners about it, I always say the mouth is good at keeping infection in the mouth. Occasionally it'll leak out and you have an abscess outside the face or drain tract below the jaw. They'll breathe in some stuff and get some either upper respiratory or lower respiratory infections, things like that. But for the most part, it stays there. I mean, that every dog out there has some sort of periodontal disease, and not every dog has, liver infection, kidney infection, heart infection, all the things that we glorify when it comes to dental infections. They don't happen that often, or we just don't correlate them directly. So how do we treat dental infections? We treat dental infections by treating the actual source. You don't throw antibiotics at it. You go in, you take the tooth out, you debride the area, you treat the tooth endodontically, those things. You don't throw antibiotics at it. So this is my rule that or what I tell owners, which is kind of my rule now. So the splinter effect. So teeth, whenever they get bad, they're basically splinters. The body's trying to get rid of them at that point. There's infection all the way around it. It's just that the periodontal ligament is so strong, the bone around it is so designed to keep that tooth in that it's keeping the tooth in. But the body wants that tooth out because it's causing this infection. So the moment you pull that tooth and get that splinter out, everything heals up. So this guy's got the splinter in his hand, you pull that splinter out, all that inflammation and redness basically goes away overnight. That's the same story with dental infections. So many times these animals have these huge infections, even where the bone looks like it's osteomyelitic, and you pull the tooth and all that goes away. And it goes away quick. I mean, animals feel better quickly. So just think of teeth when you talk to owners. Bad teeth are splinters. Take the splinter out, all that redness and infection and everything goes away with it. So I'm going to beat this horse. I'm sorry. Antibiotics should not be the source of removal of the infection. You should extract, debride, endodontically treat. Only use antibiotics if there's a reason afterwards. So I'm sorry I made this as big as possible. It's still kind of hard to read. But the CDC used the information from the ADA, and I put this one up first. There's another flyer or flow chart after this that will kind of make this a little bit make a little bit more sense. But DCDT is the definitive conservative dental treatment. So basically that means treat the tooth. So extract, root canal, debride, medicate, or debride and flush. So if you can do those things relatively acutely within a few days, prescribed antibiotics is only when there's basically an acute infection there. So periodontal disease is never really an acute infection. Sometimes you do get abscesses that blow up, and those are times that you would potentially do it. So if there's swelling, things like that, inflammation, swelling, heat, pain, those are potential reasons to do it. But also, if you can go in there and take that tooth out that day or the next day, you may not even want to throw antibiotics at it. You just throw anti-inflammatories at it and make the dog or cat feel better for that night, and then take things out. Whenever, like if you're referring to us, it's going to be a little bit. There are times to prescribe antibiotics. Basically, if you've got, again, the same thing, an abscess, whether or not it is active or not, you could potentially throw antibiotics at it. So I will elaborate on that with the next slide. So this is the kind of the flow chart of what they mean on that right side of the last chart. So pain or swelling, that's the first thing. If you have pain or swelling, that's when you use antibiotics. If you don't have pain, or if you don't have swelling and you just have pain, you typically don't use antibiotics. So it's a swelling that pushes you towards antibiotics. And then they go on to kind of break it down into what antibiotic to use. So penicillin allergy, we don't really worry about that too much in pets, but their first line for people that don't have penicillin allergies is going to be amoxicillin. And then if they do have a penicillin allergy, but not anaphylaxis, they're going to do cephalexin. If they do have anaphylaxis, azithromycin, because technically cephalexin is close enough to penicillins to push somebody into anaphylaxis potentially. So, and then if the first line fails, then you're going to go and add metronidazole to it. And then if that doesn't, or you could just discontinue the amoxicillin and switch to basically clavamox. So they're starting with a very early generation, very low strength antibiotic, and then working their way up, versus just throwing everything at them at the beginning. The other thing to note is that they have pretty short courses, so 3 to 7 days, 3 to 7 days, 7 days, 7 days, things like that. So this is only whenever surgery is not a quick option. So basically if it's over a week out, that's whenever I would consider doing antibiotics. So to summarize that, antibiotics should only use when you can't physically eliminate the infection source, and only prescribed for a few days. So that was kind of the older data. The newer data says 2 to 3 days. So very short courses. Not what I've been doing. So we're changing that, although I don't use antibiotics enough to actually remember that I need to change that. So don't be this guy. So yeah, like I said, don't be the person that just gives out antibiotics. Don't give long courses of antibiotics. So one of the things that I don't think we do enough is try to figure out what we're actually treating. Now there are some things that are very, obvious, infection-wise, that you pretty much know what bugs are there, and so you may not have to always do this. But culture and sensitivities are good to have, and then the DNA sequencing is a newer thing that we've started to use here that I'll go into as far as the benefits of that over just regular culture and sensitivity. So culture and sensitivity, pros and cons. Pros, obviously potentially IDing the actual cause of the infection, and then also the sensitivity rating for certain antibiotics to that bacteria, and it's actually determined on a culture plate, so you know exactly what they're seeing. It can be used to monitor for antibiotic resistance because it's not just you have bacteria A, so these antibiotics are good for it. They actually do grow it with the antibiotic beads on there. The cons are, it takes a while to grow these things, and then a lot of things don't grow on these plates. So you're usually just doing the aerobic bacteria. Some anaerobics will grow, but you have to collect them especially, and even those sometimes don't grow. And then fungals and things like that, everything doesn't grow quickly too, and so it could take too long for you to actually get a good result. So, and the last thing, which I don't think matters anywhere you go, but false negatives and positives, if not collected properly, so if you get a little contaminant on there. My dog, or the DNA sequencing, does a little better job, I think, of filtering this out than the cultures do. But so DNA sequencing, so the pros, so relatively rapid results, just because I have to just run it through the machine, and so it doesn't take as long. Very sensitive, so it picks up everything out there, so fungal, anaerobic, aerobic, everything, because it's just basically chopping things up and figuring out what DNA is in there. Also, it can ID antibiotic-resistant genes. At the end, I have one of the cases that I have results from, and I'll show you all the things that it has in the report. False positives. You definitely get false positives in the sense that those organisms are in the report, but it gives you the report in the amount of organisms that are in there. So unless you really are like swabbing the outside of the cheek instead of the inside of the cheek or something really stupid, you're going to get relatively good numbers from it. It's more expensive. I think they said roughly $100 more than a regular culture sensitivity, but I don't know if that's owner costs or our cost. And I don't know what our cost is for it, so sorry. But my dog, this is kind of summarizes their why they think they're better than other places. But my dog's up in Irvine, so it's actually kind of cool. They're somewhat local. But these are the big pros that I see. So you get to get all of the information, so all of the bacteria that's there, all the fungal things that are there. And then you do get the knowledge that they have from the genes that tell you what. It's kind of cool because you don't just get, it's resistant to this bacteria. It tells you why. Like it has this pump that prevents it from, the antibiotic from doing whatever it does. Biofilm compatible. Biofilm's big deal in the tooth world. And then it's not dependent on growth. So, that's another thing that, like I said, it picks up all the organisms in there. Also, one other thing that's kind of cool, but you just send it in. You don't have to do anything really special. You just put it in their little vial they give you, and you don't have to keep it in the refrigerator or anything like that. As long as it's not crazy temperatures, it does fine. Also, I'm not getting paid by them. It's just cool. So, Brook talked probably a little bit about what's in periodontal disease as far as bacteria goes. But just note that these are the most likely in periodontal disease. So whenever it changes from normal, happy flora to periodontal disease, this is kind of what shows up. And also note that they're all gram negatives and they're all anaerobes. And so if you are going to do a culture in sensitivity, anaerobic culture is going to be your thing, or the my dog, because the aerobes don't matter here. The other thing is I started this one because it's on the top 10 lists for resistance. So Pseudomonas is one of the ones that's in there. So I think everybody knows of this saying that 85% of 2-year-old dogs or older have some sort of periodontal disease. It's kind of like the go-to whenever you're talking to owners about anything when it comes to mouth diseases. This is a very dense slide, and I apologize, but there's no way not to. I tried to thin it down as much as I could, but unlike people, our pet periodontal disease, especially in dogs, it creates a biofilm. The biofilm is very resistant to everything, but it's also very complex. I know this was in Brook's lecture, but it has everything in it. Everything in it. And so they are, and this is something that's kind of out there in left field, but they're actually even looking for, looking at cat stomatitis being caused by fungal disease. So, it might come out that that's what's going on. So, because it's in these biofilms. So, we know that it happens quickly, 24 hours. I always tell people 2 days. That's why you brush. You make sure you brush at least every 2 days because you're trying to beat that biofilm before it really builds up and turns into something too hard to brush off. But it starts to form in 24 hours, starts to get hard at 48 hours. So brush at least every 2 days. The other thing that happens is you get the heritable resistance turning into a phenotypic resistance. So what that basically means is, the heritable is just basically whatever that single bacteria has in it to fight it does it. But when it's phenotypic, it basically turns into its own organism, and so it uses whatever is available in there to fight off things, so it gets more resistant. And then it also does quorum sensing, so it basically turns into a living, breathing thing and like reacts to stuff, which is kind of weird but cool at the same time. So antibiotics can't penetrate biofilm. Like as soon as it becomes a biofilm, it's like crazy more resistant to antibiotics. The other thing to think about too, there's no good way for antibiotics to get to something that's on the surface of, like, it's like antibiotics trying to get the bacteria on the top of your fingernail. Like there's no blood supply there, there's no fluid going there, so it's just not going to get to it. So I think Dr. Niemiec talked a little bit about some of these studies, but bacteremia is a thing that happens whenever you have periodontal disease, almost anytime you do anything with your mouth. So they did this on people, but people with just periodontal inflammation, so just gingivitis and potentially a little bit of periodontal disease. Chewing caused 20% of the people to have a bacteremia. Brushing, which I thought was weird that it was less than the other, but brushing maybe because you're taking it away. And then scaling, so actual cleaning. They actually found that scaling was, even on the most recent dentistry paper, they found that scaling was probably the cause of the bacteremia more than even tooth extraction. So just remember 20% chewing, because 30% with dental extractions. And this is just one human paper out of Africa. There's a bunch of different papers, and all of these can be anywhere between 0 and like 90%, but most of them kind of center around the 20 to 40% range, so I picked one that was 30, just because it seemed to be in the middle. But the fact that, you get the same bacteremia eating dinner as you do taking the tooth out, just goes to show you that when people freak out about getting infection during a dental procedure, they shouldn't, because they're more likely to get an infection just living their life. So the sooner you get that tooth out, the sooner you actually don't have to worry about infection. So because that rate goes down, obviously, if you treat the infection. So this is the paper that I think Dr. Niemiec talked about. It's really new. It actually just came out. So all the dogs in this study, we did 13 dogs, but all the dogs in this study needed an extraction because of periodontal disease. I think eight or 9 of them had periodontal disease 4, and then like 1 had 3, and 1 had, or 2 of them had 2, or 2 or 3 of them had 2. So they did 5 blood draws. So 1 pre-op whenever they put the catheter in, 1 when they started scaling, 1 whenever they extracted the tooth, 1 at the end of the procedure, and then 1 an hour after the procedure. They only had 4 patients out of the 13, so it was like 30-something%. I think, if I did my math right, had positive cultures at any point during the procedure. But all of the cultures were cleared in an hour. So before most patients leave the hospital, or almost all patients leave the hospital, that bacteremia is going to be done. So you're going to see, it's going to either happen or not in your hospital. So, and no antibiotics were given at any point during these procedures. So the body just clears that on their own. So the dental college has their statement. I still think it's kind of vague, but I'm going to read it to you because that's what I'm going to do. Sorry. Antibiotics should be reserved for animals that are immune compromised, have any underlying systemic disease such as clinically evident cardiac, renal, or hepatic disease, or when severe oral infection is present, and should not be used as the sole therapy and treatment of chronic periodontal disease. So they even throw that in at the end. Sole therapy and and periodontal disease, it should not be used. So, yeah. And then the cardiologists kind of talk more about the cardio part. Antibiotic therapy is not recommended in the treatment of endocardiosis with or without the presence of a cardiac murmur in the dog. So a murmur is not a reason to do antibiotics. Endocarditis is mixed with endocardiosis a lot. And so if you have endocarditis, you are sick, you need antibiotics, but you do not need a dental procedure. You need to survive the endocarditis, get better, and then we'll worry about your teeth. So, yeah. And chances are endocarditis was not caused by your dental issue. They go back and forth every 5 or 6 years on that, where maybe 10 years, where they'll think all bad things come from teeth, and then there'll be studies that say, no, it's from somewhere else. We're in the no, it's from somewhere else part of the timeline right now. So this is my personal thing. I actually just added something to the next slide this morning. So when am I going to use or not use antibiotics? So if a patient is systemically ill or immunosuppressed, those are going to be the ones that I will consider. Now, this is still considered using because it depends on, the stability of the disease and just how diseased they are. So diabetes is one of the ones that I lean a little bit more on doing antibiotics. I still don't do it a lot because most diabetics that are coming to me are pretty well managed. I'm not usually getting the brand new diagnosed that we don't even have things regulated because I don't want to deal with that. That's why I'm a dental specialist. Yeah, it's rare for me to get a truly wild case of diabetes. Implant within 1 month. It used to be that I was implant ever, and then I went implant down to 6 months. And then now the more recent thing is if the implant, if the dog has hair growing back where the implant was put in, it's probably fine. So, within a month, which you're probably not doing a dental procedure within a month of, getting TPLO or something like that. So it's pretty rare. Indwelling catheter. So it doesn't have to be a catheter. It can be a feeding tube. But those types of things. Again, probably not doing a lot of procedures that way. I get some because of the cats with stomatitis sometimes will come with me with, or broken jaws will come to me with E-tubes and things like that. I don't always do courses of antibiotics. I will give an injection during the procedure and that's it. Cardiac implant. This is one that's probably not right, but I'm too afraid to take it off the list because when the human dentist talked about it, he's like, yeah, we don't care. Once they're in there for a while, they're either, it's the same thing. That bacteremia happens every time they chew. They're not going to get infected whenever you do dental stuff. However, my patients that get valves put in that flew to Japan, stayed in Japan for a month while their dog got their valve and then flew back. I don't want to be the person that screws that up. So I will still throw some antibiotics at them. Our anesthesiologist still wanted me to throw antibiotics at them. So yeah, it's probably not right, but it's so rare for me. I mean, I've got probably 10 or so patients that have had valve replacements, things like that. I don't do it for pacemakers anymore. Yeah, because I don't know, they said that that's not a thing. So it's just like any other implant. So I'm not going to use it on any healthy patient, obviously, well-managed diabetes and older implants. So ones that have been around for a while. Do you guys have any cases that I didn't put on that list that you? So surgery type. So this is another thing to consider. So this is one that I added this morning because my first consult was surgery with the radiation site, and Dr. Lyon's surgery was surgery with the radiation site today. So it's one that we've all treated in the last couple months a couple times. So and that's the one that's not that we were talking about when I was talking about using doxy. That's the case. So surgery within a radiation site, I'm getting to the point that I'm going to throw antibiotics at them just because they're so hard to heal. But my general rule is if the infection is in where I think infection should be for the mouth, so just around the tooth, gum line, you can see pus coming out of the gum line. I don't care about that. If it's coming out the side of the face, that's when I consider it. It's draining out the bottom of the jaw. That's what I'm considering it. If it's in the lymph node, you got a big swollen lymph node, and you think it's from infection, inflammation, those are reasons that I would consider it. If it's still in the mouth, I don't care about it. So with that, the second part of that is active swelling, inflammation that hasn't ruptured. So once they've ruptured, I don't worry about them as much because it's draining. It's basically done. It's pulling back to the tooth by doing that because it's letting everything drain out, and that infection goes back to the tooth for a while before it kind of collects back up and then pushes out again. So if it's draining, I don't think you need antibiotics. So that dog that has the upper fourth premolar that's infected, that is ruptured, I don't think they need antibiotics. The ones that's swollen and is painful and hot, those ones I would consider antibiotics because you could potentially get it before it ruptures and kind of pull it back in. Or you could go under and surgically drain and flush it. But if you're going to do that, take the tooth out. So implant placement. So fracture repair, if I'm putting in, especially in an older fracture, not the one that just happened that day, if I'm putting wires and things like that in there, I think it's worth throwing some antibiotics just to protect those wires while they heal, because you close everything, but all that you closed over was just nasty before. So larger surgeries, so big ectomies, big mass removals, things like that, I'll do it. Phytopulp therapy, again, probably things that aren't happening in the general practice world, but those need to stay real sterile. Luxated and avulsed tooth replacement, that might be something you guys do. If you're going to put it back, especially if it's been any time at all, it's worth throwing antibiotics just to make sure that bone around it doesn't get infected. I've had a couple where the bone dies. I don't know that it would have helped if I had antibiotics or not, but that's my thought now. Routine extractions, I'm not going to. Root canal therapy, I'm not going to. Small mass removals, gingivectomies, and active draining tracts, I don't care. Like, those are all going to be treated by getting rid of that infection. So anything I don't have on that list that you guys have questions about? Okay. So we're almost there. So based on the human guidelines, this is going to be my new push here. We've sort of started talking about it with the residents just because I do think that, I think that we see more side effects of antibiotics than we do see good things from antibiotics. So, and this is what I tell people whenever like an owner pushes me for antibiotics. There was a guy that did a presentation probably like 5 or 10 years ago at the dental conference, and his thing was they took all the data from the American Heart Association and the American Dental Association, and basically they found that for every like 2.5 million people that get prophylactic antibiotics, there's one person that actually needs it. So you have to give 2.5 million doses for one person to actually need it. And so if you do that in your practice, none of us are going to see 2.5 million patients. Probably all of us in the room together are not going to see 2.5 million patients, because I did the math last night because I'm weird. For me, I actually will do less than 14,000 surgeries in my career if I work for 25 years. So that's, 0.005, so percent or 0.5% of the 2.5 million. So, and then you look up the rate for just regular old like adverse reactions to just Plavmox, and the reverse reaction rate is like 10% or something like that. So you're going to get a lot more issues than you are good things out of that. So 2 to 3 day course of amoxicillin or cephalexin. So right now we're doing Clavamox, so that's that. You're higher up on the scale than you probably need to be using Clavamox, and even clindamycin, you're up higher on the scale than you probably need to be, because you should, like I said, be using these lower generations. And then if I don't get a response in the just 2 to 3 days, then you can add in metronidazole or switch to Clavamox at that point. Honestly, it's cheap for the owner too. So yeah. So there are alternatives out there. So laser therapy, photodynamic therapy are out there. But the big thing is just treat the source. So it's my last meme. So yeah. So if you need antibiotics, what school did you go to? So yeah, questions out there? Yeah.
Are you still giving ampicillin IV like at the beginning of a?
So really the only cases that I would be doing that for are jaw fractures and big surgeries, like where I'm doing a maxillectomy, mandilectomy. Can't think of really anything else. It probably isn't wrong to do it with the radiation therapy cases, but outside of that, I don't see a reason to do it. Especially knowing what we know from that more recent paper that, yes, they get the bacterium, but it goes away. So, yeah. Yeah.
That slide that was before this where you had the orange and yellow guidelines that you outlined, was that more for like for before you extract the tooth guidelines, if there's an abscess or something, or is it something that you
So this guy?
very extensive diseased tooth with diseased jawbone around it, for after the surgery, at what point in the treatment timeline?
When would I do this? So this is whenever I think, so this is if I can't get in there right away, this is where I'm going to throw it at, or if I am done with my procedure and I don't think I got it all, which usually means that I did my surgery right. Pretty rare. I would consider this for the same reasons why I would consider the IV antibiotics. So post-implant placement, so jaw fracture repair, the radiation therapy, and I forget what the third one was, but yeah, so very rare. Yeah.
What about in cases, I actually talked to Dr. Greer a couple months ago about a patient who was paranasal and just the maxilla around the paranasal was trash.
Yeah.
So we took the tooth out, there was a bunch of nasty bone that was debrided out, and then 20, I don't know, maybe 48 hours later, I don't remember exactly when, sometime very shortly after the procedure, she got quite a bit of soft tissue swelling around her cheek and just around there.
Definitely,
of her
yeah.
face. That's a case where you would
Yeah,
start
yeah,
antibiotics.
yeah. And that's one that it may have been right to start it right away. Yeah, I have So technically what you should do is take said bone that you took out, culture it or my dog it, and then also start like just the basic antibiotic course here, and then see what it comes back as, and then you could potentially change it based off of that. It's just, well, a lot of us don't think that way just because we're just used to throwing regular antibiotics at them. But yeah, that's definitely a case that I think I, probably would have started this real short course. And
Just for like the way it looks like after you debride it.
yeah. And so, yeah, that's what Dr. Long did today is just, whenever he debrided that nasty bone in there, he's going to throw antibiotics at it, and while we wait for my dog to come back.
So to clarify, so I had somebody send me a picture today of a dog that looks like it probably has a carneosal tooth abscess, but it hasn't ruptured yet.
That's-
And I can't get it until a week from now. So you do like 2 to 3 days of amoxicillin
Mm-hmm.
and still schedule it then for the extraction like in a week.
Yep, because it's going to knock it back to the point that you can get in there. Now, if it ruptures between the time you write the prescription and they pick it up, then potentially maybe not do it. Yeah. Anybody else? I do have an example of my dog, one of the my dogs. If you guys want to come up and look at it, or I can actually put it up on here. It's not going to be, available to the people outside because it's not part of the PowerPoint. Sorry, but yeah, they're pretty cool. It's kind of nerd out a little bit on it, but because you definitely get a lot more variety in what's in there than what you're used to. It's like all of the species you learned about in vet school and that you never thought you'd have to think about again, but they're there. So, cool. All right, guys. That's it. Yeah, no problem.